Good morning, doctors. I am Dr. Dua Haider. I am a lecturer in internal medicine, gastroenterology unit. أنا دكتورة دعاء حيدر، مدرس أمراض البطنة بوحدة الجهاز الهضمي. والنهارده احنا هنتكلم على الابdominal examination. أول ما ببدأ مع البيشنت examination طبعا المفروض إن أنا introduce myself للبيشنت، وكمان ببدأ ask him for his name and باخد consent منه إني هكشف على الابدومن. ازي حضرتك؟ اسم حضرتك ايه؟
سامي.
استاذ سامي. انا دكتوره دعاء حيدر، مدرس امراض البطنه بوحده الجهاز الهضمي، وانا هكشف على بطنك.
اتفضلي.
تمام؟
اتفضلي.
طيب first of all انا بقف على الرايت سايد اوف ذا بيشنت، ما ننساش كده. تاني حاجه اني البيشنت بيبقى supine position علشان انا هبدا الانسبكشن اوف ذا abdomen. كمان ممكن يبقى 1 أو 2 بيلو تحت البيشنت علشان اعمل شويه ريلاكسيشن للابدومينال ماسلز. وبعدين ببدا اعمل uncovering للاريا اللي انا هعملها examination، وهنبدا من اول النيبل اريا او من البريست للجوينت المفروض، وما انساش اني كمان هعمل examination للباك. تمام؟ هنبدا بالانسبكشن اوف ذا abdomen. اول بوينت في الانسبكشن اوف ذا abdomen هي الشيب او الكونتور بتاع الابدومن. عشان اعرف الابنورمال لازم اعرف النورمال. النورمال كونتور بتاع الابدومن بيبقى فلات او بيبقى slightly scaphoid. فلات يعني مع اللاين بتاع الشست، او slightly scaphoid. طيب علشان احكم على البيشنت لازم ابقى عند الفوت of the patient او الهيد of the patient علشان اشوف الشيب of the abdomen واشوف السيمتري بتاعت الابدومن. فبقف كده عند الفوت of the patient وابتدي اشوف اي localized bulge او اي asymmetry موجوده في الابدومن. كده الابدومن عندي symmetrically distended، زي ما احنا شايفين الابدومن هنا distended، مش فلات ولا سكافويد. الديستنشن بتاع الابدومن ده ممكن يكون اسباب سيمتريكال ديستنشن ده بنقول عليها 5F او اولها F. زي اول حاجه الفات ممكن cause of الابدومينال ديستنشن. تاني حاجه الفيتوس في الفيميلز، او الفليتوس gaseous ديستنشن، او الفلويد زي الاسايتس او الفيسس. تمام؟ طيب ده لو كان symmetrical distended. لو كانت localized distension او localized bulge بشوف بقى ايه سبب اللوكالايزد bulge ده. هل هو حاجه intra abdominal او extra abdominal في الابدومينال وول، يعني زي الهرنيا، او حاجه جوه زي ماس او زي اورجانوميجلي. تمام؟ يبقى ده اول ايتم. طب لو لقيت البيشنت ده severely scaphoid abdomen ممكن يكون اسباب marked wasting زي في المالجنسي او زي في التي بي. يبقى ده أول item in the abdominal examination. Second item in the abdominal examination is the flanks. The flanks which is the sides of both abdomen. بتبدأ من ال last rib للإلياك crest. المفروض إن الفلانكس دي it's a concave in shape. Okay? Any bulge in the flanks it will be slightly convexity or more convex. تمام؟ Causes of this full flanks بنسميها الفول فلانكس. الكوزز بتاعتها ممكن تكون organomegaly، ممكن يكون فات او ممكن يكون فلويد. يبقى اول حاجه كانت الشيب، تاني حاجه كانت الفلانكس. البيشنت هنا عنده فول فلانكس. third item هبدا بقى من فوق starting from above so not to miss any item. السبكوستال انجل. السبكوستال انجل it is the coastal angle عند الكوستال مارجن. هنا مش باينه عند البيشنت، فانا ببدا احط التو اندكس فينجر علشان ابدا ابينها. السبكوستال انجل هنا عند البيشنت it's wide, it's obtuse angle. Normal subcostal angle it's right angle or it's 90 degrees. Less than that it will be acute, and more than that it will be obtuse. What are the causes of obtuse subcostal angle? Obtuse subcostal angle causes may be abdominal or chest causes. Chest causes like emphysema, or abdominal causes like anything that increase the intra-abdominal pressure like organomegaly or ascites. What are the causes for acute angle? Acute angle mainly it's chest causes like pigeon chest or flat chest. So this is the third item. We will get to the other item, which is the epigastric pulsation. This area at the angle, this is called the epigastric area. As we know that our abdomen is divided into 9 quadrants by 2 vertical lines and 2 horizontal lines. This is the epigastric area, and this is the umbilical area or the umbilical region, and this is the hypogastric area or the suprapubic area. Right and left, they are called the hypochondrial area or hypochondrial regions. Right and left flanks or right and left lumbar regions, and right and left iliac regions. So this is the epigastrium or the epigastric area. We are going to recognize if there is any epigastric pulsation in this area. Epigastric pulsation, we are going to ask the patient to stop breathing in expiration. طلع نفس واكتمه. We are going to recognize that this is a slight pulsations here in the epigastric area. What are the causes for epigastric pulsations? Epigastric pulsation, it could be coming from downward, upward from the aorta. Okay, I can put my hand like that to feel it. Pulsations coming downward, upward from the aorta. And the causes for this, it could be normal in some patients, or it could be normal in thin people, or it could be transmitted from the aorta due to a tumor in front of the aorta or an aortic aneurysm, which is called expansile pulsations. Or these pulsations can come to my tips of the finger, and this is due to a right ventricular enlargement or dilatation or hypertrophy due to a volume or pressure overload. And another pulsation can come from the liver. This is will hit my index finger, and the causes for pulsations in the liver is due to congestion of the liver due to right side heart failure, constrictive pericarditis, pericardial effusion, or it could be aneurysm in the hepatic artery, or arteriovascular shunt, or a tumor underlying the liver. So these are the causes for hepatic pulsations. This is our fourth item. We will go into the next item, which is the divercation of the recti. What are the recti? They are 2 longitudinal parallel muscles in the abdomen. They are strong muscles, but they will become weak if there is increase in the intra-abdominal pressure, which will weaken them. So I'm going to examine it by asking the patient to slightly sit down, please. Can you حضرتك ممكن تهمي كده شوية معايا? Okay. Can you recognize this? These are the bifurcation of the recti, which is bulging of these abdominal contents due to these weak muscles. Okay, and this is of course due to increase in the intra-abdominal pressure. It occurs in ascites. It occurs also in some weak muscles, like in pregnancy, recurrent pregnancies. Okay, when the patient is going to sit down, I'm going also to recognize any hernial orifices elsewhere, like per-umbilical hernial or femoral or inguinal hernia. Okay, and if there is, I'm suspecting hernia, I'm going to ask the patient to cuff and put my hand like that to feel the impulse on cuff on the hernia. Okay, the second item, or the next item, it will be the umbilicus. The umbilicus is a very important item because in it we have several items we should fulfill. Okay, the first is the site of the umbilicus. Normal site of the umbilicus, the normal site of the umbilicus, it is midway between the xiphisternum and the symphysis pubis. Here, our umbilicus is shifted downwards. So, what are the causes of shifting the umbilicus downwards? Is due to organomegaly, splenomegaly, hepatomegaly, or ascites, or any tumor in the upper abdomen. So, what are the causes of shifting the umbilicus upward? The umbilicus could be shifted upward in tumors in the pelvis or ovarian cyst. Okay, sometimes the umbilicus shifted left and right to the other sides. Okay, this is due to maybe a scar of a surgery which will pull it to the same side, and sometimes in hemiplegic patients. The second item in the umbilicus is the shape of the umbilicus. The normal shape of the umbilicus is that umbilicus is inverted. So abnormal shape is to be flat or to be everted outwards. Okay. What are the causes of this eversion of the umbilicus? Is increase in the intra-abdominal pressure like ascites and organomegaly also. Okay, the third item in the umbilicus, we have to recognize if there is any pigmentations around the umbilicus. Normally there is no pigmentations around the umbilicus. Abnormal to find any pigmentations around the umbilicus, like to be bluish or greenish pigmentations, like in the internal abdominal hemorrhage, in which is called the Cullen sign, like in acute hemorrhagic pancreatitis, or in rupture spleen, disturbed ectopic pregnancy, any internal hemorrhage in the umbilicus. It will be reflected here. Okay. Other causes, we can find brownish pigmentations around the umbilicus in lymphomas, and also we can find pigmentation in TP peritonitis. So this is the third item in the umbilicus. The fourth item is to find any dilated veins in the around the umbilicus. These dilated veins is called caput medosa. What's caput medosa? It is the surest sign of portal hypertension. One of the surest signs of portal hypertension is due to the anastomosis between the portal and the systemic veins. So the veins will appear like sun rays, as if the umbilicus is a sun, and the veins, they are like rays coming away from the umbilicus. They fill away. So the direction of flow, it will be from the umbilicus outwards. How to differentiate diagnosis between caput medosa and the inferior vena cava obstruction? Inferior vena cava obstruction, the direction of the flow, it will be from downwards upwards. So we are going to do what's called by milking test. Milking test is to choose any vein which is apparent to me, and then empty this vein, but we must choose a vein below the umbilicus, because above the umbilicus, the direction of the flow of the caput medosa and the inferior vena cava obstruction will be the same. So I have to choose a vein below the umbilicus and then close the vein from both sides. And I will leave this finger. So if the direction of the flow is coming downward, upwards, so this will be obstruction in the inferior vena cava. If no, so I'm going to leave my finger, which is the upper one. Okay, if the direction of the flow is from upward downwards, so this will be due to portal hypertension, caput medosa. Okay. We can find also nodules around the umbilicus, which is called cystomary nodules, like in the malignancy, in intestinal malignancy or the internal malignancies, and you can also find discharge around the umbilicus. This discharge due to maybe a sinus, due to this discharge will disturb pus due to abscess, or a fistula by any site, like in the intestinal fistula, so the discharge will be feces, or a urinary fistula, or biliary fistula. Okay, so these are the items for umbilicus. We have to fulfill all these items of umbilicus. It's very important. The next point will be the suprapubic area. The suprapubic area, we will recognize any bulge in this area and the hair distribution. So any bulge in this area, like swelling in this area due to a full urinary bladder or ovarian cyst, and the hair distribution. It's important for the male hair distribution, because the male hair distribution, it's like a triangle where its apex is the umbilicus. The hair distribution here, as we see, is scanty, or it's a feminine hair distribution. This is due to decrease in the destruction of estrogen in a hepatic patient, and also due to loss of activation of the androgen, which occurs normally in the liver. Okay, so after the suprapubic area, we are going to recognize any scars in the abdomen, and if we detect any scar in the abdomen, we are going to tell the location of this scar and for how. Like here, we got a scar. This is in the due to appendectomy in the right iliac fossa. Okay, we can find a midline scar or a paramedian scar or a gynecological scar in the suprapubic area, or we can also find a scar for cholecystectomy in the right subcostal area. Or as for a liver surgery, we can find what's called Mercedes pins, which is a scar taking the right and left subcostal and extending upward till the xiphisternum vertically, which is called the Mercedes pins. We can also recognize if there is any pigmentations all over the umbilicus, all over the abdomen, and we can also recognize if there is any dilated veins or if there is any stria in the abdomen, and this stria due to the breakdown of these elastic fibers due to distension of the abdomen that can occur in tense ascites. It can occur in pregnancy also, and it occurs in Cushing. Okay, and the next item is the respiratory movements. Respiratory movements, we know that with respiration, the abdominal wall muscles is very important in this respiration, in this process. Restriction of this movement or respiratory movement in the abdominal muscles, this may be due to peritonitis or may be due to tense ascites. Okay, here the patient is still having his abdominal wall muscles in respiration. And the next item, which will be the intestinal movements. Normally I cannot see the intestinal movements, which occurs small intestinal movements every 15 minutes and the large intestinal movement every 30 minutes. But I can see it in patient having a problem like intestinal obstruction. So the small intestinal obstruction, it will be around the umbilicus and it will occur every 15 minutes. And the large intestinal obstruction, it will be like a horseshoe peristalsis. I can see the colon, okay, and it occurs every 30 minutes also from the right to the left. Don't forget that we have to check the genitalia for any edema, for any ulceration, for a varicocele, for undescended testicle, okay, and for hernial abscess. And don't forget also to check for gynecomastia, which is increase in the size of the breast and puffiness of the nipple. And if we do palpation to these areola, we will find like a nodular swelling behind the nipple. Lastly, don't forget to check the back. The back is important also. ممكن حضرتك تقعد. The back is important. تقعد. To check for the back for the renal angle. If it's full or empty, which is the angle between the 12th rib and the lumbar vertebra, okay? And don't, we can also recognize if there is any edema in the abdomen by inspection. And for the vertebral colon, it's if there is any kyphosis, scoliosis, and if there is any scars or pigmentations at the back. Okay, lastly, we are going to, شكرا لحضرتك, we are going to say goodbye for our patient. This is what all for the inspection. Thank you. شكرا لحضرتك.